Thank you, Raul. I think you probably should close them based on the talk, but I'll tell you, even if you close them, it doesn't mean that it's a guarantee that they'll never occur. So it's an important take-home message with small bowel obstructions is to make sure that you are always vigilant. So thank you, Raul, and thank you to SAGES for another great meeting, and talk to you a little bit about small bowel obstructions and bariatric surgery. Okay, thank you. So here's the incidence. You can see here a couple of things. One is the laparoscopic revolution has touched bariatric surgery very deeply in that over 90% of the cases we do in bariatric surgery are laparoscopic. But the one thing that's a negative about laparoscopy is it's probably going to have a higher rate of obstruction. Why is that? You know, with open surgery, you're just going to cause a lot more adhesions. And open surgery's maybe only advantage is that it probably has less of these obstructions as a result. The other thing to kind of keep in mind is why these happen. There can be a lot of reasons, you know, obviously just adhesions between the bowel, there can be abdominal wall hernias, and of course the different hernias that we encounter. But the big one, the one we have to be most concerned about that can be life-threatening is an internal hernia, particularly after gastric bypass. And with that in mind, again, you have to be very vigilant about it because it can create a closed loop obstruction that can easily perforate. The abdominal wall hernia stuff, one thing to keep in mind about that is timing about when you should fix these abdominal wall hernias. With ASMBS, we did recently a closed claims registry of about 250 malpractice cases, and within it were people that had done concurrent abdominal hernia repairs with patients and had leaks that developed afterwards. So we have to get the careful timing around these abdominal wall hernias, particularly given the fact that as patients are losing weight really quickly, sometimes those hernias that you fix don't stay fixed. A couple of things to kind of keep in mind here is that this is different from our traditional small bowel obstructions. And this paper here just demonstrates pretty nicely the difference, and that is essentially that the timing when you take people back for bowel obstructions is different for bariatric surgery. It generally occurs earlier, and you generally need to have surgery to make this happen. And you can see here that the time of surgery when it's bariatric is usually a day for intervention versus 3 when it's non-bariatric. So again, you want to work on that sooner rather than later. Here's one of those examples of the abdominal wall hernia, and you know, if you're obese, there's a pretty reasonable chance that you could have an abdominal wall hernia. So what's the best approach with this? And there haven't been a lot of data around this, but in general, most of us defer fixing these abdominal wall hernias till after patients have lost a significant amount of weight. In fact, one of the things we've been working on with the American Hernia Society is the idea of weight loss is prehab, where you're going to have patients lose weight before they have the secondary procedure like an abdominal wall hernia repair. They're going to get a better repair, there's going to be less pressure on that hernia repair, and it makes sense to defer it. Also, they can do their abdominoplasty if needed at the same time as that hernia repair. One thing to kind of keep in mind is sometimes we see these hernias that have a big omental plug in them, and because we want to be complete in what we do, we sweep it all down and get that omental plug out. I would recommend leaving that omental plug alone. That's kind of nature's patch, if you will, and it's good to leave it alone because if you do that, you're going to have an open space. Nature abhors a vacuum, and it will try to fill it, and what it generally fills with is the bowel, and you can end up with an obstruction there. So a couple of things to keep in mind there, but the big one is this jejunostomy potential obstruction. Sometimes it can be difficult to diagnose. CT scanning is really the best approach with this. The issue is, of course, given the fact that you've divided the stomach with a gastric bypass, is that it no longer has a point of egress. It can be a closed loop obstruction at that point, which mandates an emergency intervention. If you look here, this is exactly what can happen. In this case, it wasn't from herniation, it was from a blood clot that was perfectly situated right there at the JJ. And when that happens, you get backflow into this part of the, into the biliary-pancreatic limb. And since it's no longer in continuity, this can perforate. So it's something to keep in mind. Probably the only time a plain x-ray, abdominal x-ray is useful after bariatric surgery is to see if the remnant after a gastric bypass is dilated, because that is a big time warning sign. Here's some other obstructions that can occur. You can have the roux limb twist and issues like that, or there can be blood clots in it as well. And there is obviously potential for aspiration given how close it is to the airway. Some other rare causes that you'll see sometimes, blood, from a staple line that is bleeding, or sometimes with patients who eat things like very fibrous type foods or meat, that can cause obstruction, and you may see this from time to time. We actually make sure that all our patients have pretty good dentition before they have surgery, because it's so important that they be able to chew afterwards and make sure that everything goes down without difficulty. And dental health is very closely linked to cardiac health. If you have patients who are edentulous, check them out, because some of them could have a cold cardiac disease. With the procedure that is becoming less and less common, gastric banding, occasionally you can see some of these obstructions around the band. We are now taking more out than we're putting in when it comes to gastric bands, but you can see that there can be potential causes where it can flagpole around the tubing. And here's some more. Theoretically, with some of these new devices, the intragastric balloons, there is potential that they could migrate. The migratory ability can be mitigated depending on a couple of factors. One of the balloons is a dual balloon, so if one balloon goes down, you have the second balloon available. That's the reshape. Some of the smaller airfoil balloons may have potential for those to obstruct. There's another one called Ellipse from Allurion that is digestible, if you will. And to date, I think they haven't had any issues with those obstructing, and I know a trial is coming forward here in the U.S. Again, the internal hernia is probably the biggest concern here. And where do these occur? Well, there's Peterson's defect, there's Brolin space, and you can potentially have them all occur. But the big one that we all worry about is at the JJ, at the mesenteric defect. That's where we have our biggest concern. And I do agree that it's useful to close the defects and to use non-absorbable suture. I was of the belief for many years, the bigger you make the defect, the less likely it is for them to obstruct. The issue is that some of these patients don't come back to see you, and they may be at an outlying institution and can't be transferred in. So we close all our defects at this point. And again, you have to have that high index of suspicion. Who's at risk for these internal hernias? If you look at it, and we've looked at our data, it's people who've lost a tremendous amount of weight. Their excess weight loss is probably above 70%. Just as the abdominal fat thins out, that mesenteric fat thins out, so it can happen. If you look at the CT scan, you have that pathognomonic view where the swirl sign, which shows that the internal hernia. So one thing you might see, when people are working them up, high lipase levels, if you see that, you got to wonder that it may not be pancreatitis, that it could be bowel obstruction. And again, here you can see the different potential areas where you can see those hernias occur. And I've already mentioned to you before that it's important not to wait, but one super important tip, probably the best tip I can give you other than not waiting, is when you reduce these internal hernias after a gastric bypass, start at the cecum. If you're not comfortable doing it laparoscopically, you can always do it open. Start at the cecum, because if you go the other direction, you can actually twist it even more. So here you can see the internal hernia from the CT scan, and this is some of the stuff that you'll see with an internal hernia. You see the lymphatics are very pronounced there, that thick white. The other thing that you may see with a chronic bowel obstruction is chylous ascites. If you see chylous ascites after a gastric bypass, your first direction ought to be towards consideration of a small bowel obstruction that is chronic. That is the usual cause for chylous ascites. And just demonstrating here how difficult it can sometimes be to reduce. But again, if you start at the cecum, it can make it easier. Here you can see that reduction, and you can see the ileal veil there that allows us to start the reduction in the proper direction. So. Now, we did a trial on this a few years ago. We actually presented it at SAGES, and we randomized closing these defects, 105 patients, pretty standard group of patients that we operated on. We closed the Peterson defects. The one we wanted to concentrate on was the JJ defect, and so we closed half and didn't close the other half. And if you look at the weight loss results, they were virtually the same. There was no significant differences in weight loss results. And we had pretty good follow-up at 75% at 12 months in clinic, but 100% were contacted to see if they had any sort of issues. And what we found was there wasn't a significant difference in closure between the two groups, whether or not there was an internal hernia, at least in our study. So we didn't see a big difference. We didn't see a difference in GI quality of life where there's like pain and things like that associated with recurrent small bowel obstructions. Our recommendation is, despite how you close them, whether you close them or not, always worry about the risk of internal hernias. And I think the big risk demonstrated here with this study is that this can occur anytime. And if you look at this study, which I think is the definitive study on it, they looked at thousands of patients, and I believe this was from Sweden, and you can see here that they also did the same approach, but with much bigger numbers into the thousands. And you can see here that the closure did decrease internal hernia rates, but it did not make it zero, but it made it decline by about 50%. So closing the internal hernia can lead to less risk of bowel obstruction, but it doesn't make it zero. So finally, just to kind of keep in mind here, it is important that you close the defect in terms of reducing the overall risk of bowel obstruction. And a couple of things just to remember is don't wait. If you hesitate, that bowel can become ischemic and you have to have a high index of suspicion. CT scanning is the best way to figure it out. And again, recommendation is not to wait. And I recommend closing the defects so you can reduce the risk probably by at least 50%. Want to remind people about different upcoming events: ASMBS weekend in June, our quality meeting in New York with the college, and finally the granddaddy of them all, Obesity Week in DC in November. Thank you all very much. Appreciate the opportunity.